I'm Stephen H. Abman. I'm a specialist in pediatric pulmonary and critical care medicine, and we'll be talking about pulmonary arterial hypertension in children at all ages, neonates, infants, adolescents, and the diversity of conditions in which pulmonary hypertension contributes to a significant part of their disease.
Hi, my name is Ian. I'm from Boulder, Colorado. I am currently 18 years old. My favorite color is blue because it reminds me of the ocean. Favorite thing about the ocean is fishing. I love fishing. I was told I had pulmonary hypertension when I was 5 years old. I was going in for an annual checkup in Boulder, and my doctor there heard a second heart sound. And because we were going on a trip to India, we decided that it would be best to get it checked out. So we came down here, and later that day I was diagnosed and I had a central line put in.
Hi, I'm Dunbar Ivy. I am professor of pediatric cardiology at the University of Colorado School of Medicine, and I'm also director of pediatric cardiology and the pediatric pulmonary hypertension program here at Children's Hospital of Colorado. So the actual definition of pulmonary hypertension is an elevation in pulmonary artery pressure, that is the pressure in the lung blood vessels. And there are many different reasons that blood pressure in the lungs can be elevated, and so my job is to find out why is the pressure elevated. The diagnosis of pulmonary hypertension for me or for my adult colleagues is frequently challenging because there's a broad heterogeneous range of disorders that can cause pulmonary hypertension.
So certainly pulmonary arterial hypertension is a problem with both children and adults. There are several unique features in kids that make it a very important and different kind of problem for us to tackle. The first is the age of onset, and the nature of the diseases can differ. We have premature infants who can develop pulmonary hypertension at birth or throughout infancy. We have term babies who at birth already have sustained pulmonary hypertension that could be life-threatening. We have congenital heart disease problems that kids have that are unique to pediatrics, in which pulmonary hypertension is a very important driver of their outcomes. Although there are many conditions that have some similarities, the unique features of the developing lung and the developing lung circulation and the heart and how it works really make its therapies and understanding its course quite unique.
30 years ago, the average survival for a child with pulmonary arterial hypertension was only 10 months. And in the last decade or 2 decades, there's been a marked improvement in survival for most children to the point that the average survival is around 70%, 5 years. The time from onset of symptoms to diagnosis is still 1 to 2 years for the majority of patients.
We think that early recognition of pediatric pulmonary hypertension is important to improve outcomes and survival in kids who have this disease. The hard part of it is that often its presentation could look very similar to much more common conditions like asthma or pneumonia or other kinds of issues. So it's hard for the general pediatrician or internist to recognize what makes PH or pulmonary hypertension different from the more common or typical conditions, and not to delay diagnosis or delay referral to begin to initiate the appropriate therapies.
So in the investigation of patients with pulmonary hypertension, the history is really very important. How has the patient been feeling? Do they have dyspnea? Are they no longer able to do sports that they were able to do before? So how long has this been happening? Do other family members have a similar history or history of pulmonary hypertension? Or do family members die early or suddenly, suggesting that they may have had undiagnosed pulmonary hypertension?
When I was diagnosed, I had no prior symptoms. It was really just a matter of my doctor hearing the second heart sound in Boulder.
The majority of the time, the diagnosis of pulmonary arterial hypertension is made in a child who has shortness of breath, fatigue, chest pain, or syncope. In Ian's case, he did not have those. His pediatrician was outstanding and picked up that the second heart sound was very loud, and that led to his echocardiogram, which showed pulmonary arterial hypertension.
So I did not know a lot when I was younger, obviously when I was 5. But when I was 10, I went to my first pulmonary hypertension conference. And at that conference, I met other kids with pulmonary hypertension. And I especially talked to this girl named Rainey, who was 3 years older than me, and at the time was in a much worse state than me. She was on oxygen all the time. And that's the first time I really realized that PH was such a debilitating disease. It was taking control of her life, basically, and that's the first time I really realized that what it was doing to people. Over the years, I have been limited in what I can do with PH. At first, the main hit on me was not being able to ski anymore. I could no longer go to altitude, and before then, I was skiing all the time. I was skiing almost every single weekend, but then diagnosed and no longer could do that, not an option. In school, I was limited to physical activity as well. On recess, I couldn't run as much, obviously. And yeah, so for about 10 years from when I was diagnosed, I was relatively stable in my health. My SATs would stay pretty much normal and not change too much. But that changed when I turned about 15. When I turned 15, the pH started creeping up on me, and ultimately it slowly started deteriorating my lungs and my body in general, because it just sucks all the energy out of you. Even though it might just be a shortage of breath, it just slowly kind of kills you.
So what we've learned that really makes pediatric pulmonary hypertension different from the adult world is especially striking when we think about premature infants. We found that in our registry from our pediatric pulmonary hypertension network that about half of our cases are in so-called group 3 disease, that is lung-associated pulmonary hypertension. And most of those kids have something called bronchopulmonary dysplasia, or chronic lung disease, which develops after premature delivery. And so this has not been often the case. It's often under-recognized or underappreciated of how many infants develop pulmonary hypertension and how often pulmonary hypertension contributes to mortality. So we have an example of a 26-week infant who had a very prolonged course in the neonatal intensive care unit. It was on a ventilator for weeks, was finally discharged home on a little bit of a nasal cannula with supplemental oxygen, but 2 weeks later developed profound respiratory distress, had developed a viral infection, and was back on a ventilator in the pediatric intensive care unit with life-threatening levels of pulmonary hypertension. And so part of his recovery involved reinitiating treatments with nitric oxide, assessing other pulmonary hypertension medications, keeping him supported on a ventilator until he had good resolution of his airways disease. And then he was successfully taken off, weaned from that kind of intensive care support, and then maintained on pulmonary hypertension drugs as an outpatient for several years afterwards. And here's a child who had a huge risk of mortality, recovered nicely with a good response to sildenafil in particular over time, and right now is very active, has no signs of exercise impairment. He's an all-star in school, learning very well, and he's an example of a form of pulmonary hypertension in the past I think had been underappreciated, and certainly from the adult world never was part of that radar at all.
So there are 3 important diagnostic tests to determine the presence of pulmonary hypertension. These include chest X-ray, echocardiography, and electrocardiography. The echocardiogram is crucial in the diagnosis of pulmonary arterial hypertension, and this may show an elevation of pressure, how the right heart is functioning, but also if there's a presence of a congenital cardiac defect. If congenital heart disease is ruled out, we next begin to look for forms of lung disease. Tests to evaluate for lung disease include pulmonary function test, chest CT scan, and sleep study. If these studies are normal, then we look for even more uncommon causes of pulmonary arterial hypertension, such as connective tissue disease, thyroid disease, or sickle cell disease. So once we perform the initial diagnostic evaluation of a child with pulmonary hypertension, we need to determine the treatment. And the treatment is determined by whether a patient is low risk or high risk. In children, we consider high-risk patients those who have right heart failure, have syncope, those that by echocardiography have poor right ventricular function or fluid around the heart called a pericardial effusion. The heart cath, again, helps us to determine whether a patient is low risk or high risk. High-risk patients have high pulmonary vascular resistance, low output of the heart, and elevated right atrial pressure. We also look at BNP or NT-proBNP. These markers may be elevated or rapidly increasing as a sign of higher risk. Patients who walk shorter distances are at higher risk, and patients who have low peak VO2 during exercise testing are also at higher risks. So after a complete diagnostic evaluation, cardiac catheterization is very important in determining the treatment. At cardiac catheterization, we do vasodilator testing to see if the blood vessels can relax. If there's a marked fall in pulmonary pressure and resistance, then we can use a calcium channel blocker, which is a relatively simple therapy. If patients are lower risk, then we use oral agents. These might include an endothelin receptor antagonist, a phosphodiesterase inhibitor, or a form of prostacyclin. In patients with more advanced or higher risk disease, we choose a more aggressive approach, and this might include intravenous or subcutaneous prostacyclin or combination therapy upfront.
One of the major problems we face in terms of improving outcomes of kids with pulmonary hypertension is we rely heavily on the adult experience with these drugs. A lot of the clinical trials demonstrating efficacy have been proven exclusively in adults, and likewise some of the adverse events that occur, we rely too heavily on what adults taking these medications may show. We know that as kids develop and grow, there can be striking changes, first in body size and handling of medications, so pharmacokinetics, pharmacodynamics in terms of what drug levels may be vital for improvement. And we also learn that certain mechanisms of disease that overlap with kids may also be important with understanding the normal developing lung and its circulation. An example would be that in experimental models, drugs that may be effective in adults for treating pulmonary hypertension have been studied, and in these experimental models, they've actually been injurious to lung development. And that's unique to the developing lung to children. So we have a lot to learn about in terms of how to use these drugs, which drugs are most effective, and what kind of safety profile we should try to seek out. One example of what's different between pediatric and adult clinical trials is that there are certain metrics that we think are important for improvement, things like growth. We know that kids who have pulmonary hypertension that's most severe grow poorly. Well, that means that one of the outcomes we could look for in a clinical trial is to see how kids grow during infancy and childhood while on the medication, in comparison with those who are not receiving that medication. Similarly, cognitive development in this very delicate window of time needs to be closely assessed and monitored. And so those are some of the features that I think are very unique to children. Children sometimes don't respond fully to monotherapy with whichever medication we use. So we begin to think of what kind of add-on therapies may be of benefit. From the adult literature, we know sometimes mixing agents or combining them at the time of diagnosis may lead to more sustained improvement. Whether that's true for younger infants and children, however, remains to be studied. So for patients who really don't respond well to very aggressive therapies, these usually include the oral agents, inhalational agents, but especially systemic delivery of prostanoids, prostacyclin and its derivative. Patients who still fail to respond to that, we really have limited data on what the optimal next steps would be. We certainly have tried atrial septostomy. There now is some evidence that we do something called a reverse Potts shunt to help enhance cardiac output, even though we know we will worsen oxygenation in those subjects by worsening their shunt. And those end up being temporizing type steps, provide some stability. Lung transplantation, however, has been evolving over time, and it's been successful in adult patients. We're seeing some good success in our older children. And now the question is in those who have the most severe disease as older infants or children, who at a younger age are showing failure to respond to these interventions. Should we be trialing or applying lung transplantation to them? And we currently are. We are still trying to evaluate what the optimal approach would be, the timing for such surgery would be. But in patients and families with much consultation, we are providing and offering that as the next step for management.
So in 2015, we were talking to my doctors, Dr. Ivy, and he brought up a surgery called a Potts shunt that would basically be another exit for blue blood so that it would release some pressure on the heart. So I went to St. Louis and did that surgery, and they ultimately found out that it did not really work. We were sent back to St. Louis for the actual lung transplant. And we arrived in St. Louis on December 1st and spent approximately 2 months waiting for a pair of lungs. Finally, on January 19th, I received a pair of lungs, and the surgery was about 17 hours long, many complications, including 2 massive blood transfusions, which is usually not a good sign. But then after that, my recovery was very long. Multiple things went wrong, such as strokes, seizures, and just many things, neuroleptic malignancy syndrome. And then finally, when I got out of the hospital about 3 or 4 months later, I was finally on a steady path upwards.
One of our major concerns when families receive the diagnosis that their child has pulmonary hypertension is that there's very little established literature on this that's really specific for kids. Most importantly, there's very little literature available that really discerns differences in the diversity of causes of pulmonary hypertension. And so that's where there are some resources available now through the Pulmonary Hypertension Association, PHA, through a group called PH Aware, which also provides this information. And these are both family advocacy groups. And I really encourage families to connect with them online and provide a massive amount of support. They're doing really wonderful work for families. We also have developed a group of sites called the Pediatric Pulmonary Hypertension Network, or PPHNet. And our goal is to provide regional resources as well, and advice for caring for these kids, and also to work together as a group. Whereas we've developed a registry and database to track outcomes of kids who have PH, and also to design clinical trials and interventions, and also to provide some support for other advocacy groups as well, working with PHA, PH Aware, and others. And then finally, the American Heart Association and American Thoracic Societies are all engaged now. So one example is the PPHNet developed guidelines and recommendations for the care of children with pulmonary hypertension, and provides sort of a starting point of how we should think about these diseases and their management. And these were fully supported by American Heart Association and the American Thoracic Society. And again, they're really the starting point. We emphasize what we know, but we emphasize what we don't know. And hopefully as a community working together on many of these projects, developing better research approaches, and having long-term follow-up, we'll be able to enhance the outcomes of kids who have pulmonary hypertension.
Before transplant, I wanted to do so many things. I wanted to go camping, I wanted to go skiing, I wanted to just do everything that normal kids could do. So after this transplant, I was finally able to do everything that I could not do previously. And for the first time, I could really, really experience it. And it was amazing. It was amazing. What I would say to other kids suffering from PH is really just like, you've gotta do the things that your doctor tells you, ultimately, such as wearing your oxygen during the day, sleeping with oxygen as well as checking your pulse, everything. Even though you might not want to do it, it's for the best. It's absolutely for the best. I know I personally hated wearing oxygen. I hated wearing it at school. Everywhere I went, I would be like, I don't want to do this, but ultimately it helps you.
Pulmonary arterial hypertension is a very challenging diagnosis to make, but a very important one because this is a deadly disease. And so if we can diagnose pulmonary arterial hypertension earlier, we think that we can improve the prognosis of patients. Moving forward, my hope is that we'll be able to work with the regulatory agencies to develop specific therapies for children. And these include not only formulations, but specific types of drugs because of the special needs of children.
I'm really convinced that the early recognition is absolutely vital for improving kids who have pulmonary hypertension. What we don't know is whether early intervention for chronic therapy will change the course of disease in some of our conditions. We have very striking evidence, however, that it looks to be the case that simply using medications that have been mostly tested in adult patients will improve outcomes in kids, yet we still see significant mortality. And this occurs in a diversity of conditions. And so the challenge right now is how to enhance our drugs that we could use for therapies that are targeted specifically for different types of endpoints. Right now we use our drugs as vasodilators. Well, perhaps if we could stimulate vascular growth or inhibit smooth muscle wall thickening around the vessels, we could then more specifically identify kids who will respond to interventions and become more successful. So we have a lot more to learn from combining preclinical studies with clinical trials, and certainly what we're learning from the genetics and other kinds of biomarker studies will all enrich our ability to care for them in the future.
So in the future, I'm super eager to find out what's next. I just completed my first 14er, so that was a big accomplishment because I had never done something like that. And there's no way I could have done something like that. I'm also heading to Dublin, Ireland soon to do an internship. And from there on, I'm going to be just traveling Europe and kind of experiencing life in a new way and, just figuring stuff out.
I'm Stephen H. Abman. I'm a MD. I'm a specialist in pediatric pulmonary and critical care medicine.
I'm Dr. Dunbar Ivy, and it's been a pleasure speaking with you today about the challenges of diagnosis and treatment of children with pulmonary arterial hypertension.